Welcome, my colleagues. This is one of our dedicated online Viva session. Today's session will be about pediatric MSK. Uh, our first candidate, request control, please.
Sorry, I am on mobile. I cannot scroll right now.
Can you request or not?
No, I can't. I can't. Sorry.
Your voice is not clear at all, my colleague.
Is this clear now? Wait, let me
Mm,
try one. Like this, it is clear.
yes, like this is clear. This is a
Yeah.
35-year-old female patient 35-year-old female patient. Okay.
Okay.
Presented. Yeah. See the history, but we are in a pediatric MSK. The patient has been done this X-ray, this CT for a urology purpose. Okay.
Yes.
But to save time, she has something related to a pediatric MSK abnormality. Okay, go on.
Yes, I can see that this is uh, maybe a scout
Yes,
for yeah, this is a scout for the CT scan, and it showed
yes,
that there is a bilateral hip joint replacement.
yes.
Otherwise, I can see that the rest of the hip joints appears within normal and both femur within normal. In my routine practice, I want to
Yes, I
review
want
the
to.
previous. Yes, I want to review the previous images, images prior to the surgery to see why they replace both hip joints. Second of all, I can see that both sacroiliac joints appear clear, and I cannot see
Okay.
any obvious abnormality within the
Are you sure? See, see, 1 second.
about
So, are you sure? Are you sure there are no any obvious abnormality?
within the spine.
I don't know. Tell me.
I'm thinking about. No, I cannot. Maybe there is like lytic lesion within the left iliac bone. I cannot see the border of the left sacral bone clearly. Left sacral bone.
Yes. What else?
Yeah. What else? Okay.
Look at the spine, please.
I'm looking at the spine right now.
Mm-hmm.
Um, I can see the pedicles. Maybe one
No,
of
no,
the
no.
pedicles.
Overall, what happened for the spine? Is
The
this
spine
normal
is not.
spine?
No. There is degenerative changes seen at the lower vertebral spine.
Okay. Look here, please. What
Yes,
happened?
I can see. Yeah,
By the way, doctor, this is a 35-year-old female patient. So,
yeah,
يعني
young.
don't think or don't talk about degeneration.
I know, but it
What?
looks like degenerative. Yes. Here I can
Okay,
see that there is decrease in the height of the anterior aspect of the L4 vertebral body. The rest of the vertebral body appears within normal. Um I can see that the vertebral space are preserved and the vertebral bone marrow appears within normal.
okay. If I told you today we are talking about pediatric MSK to make
Yes,
it more easier. So,
yes.
what is your concern about this two finding in middle adult? She is not older patient. We
Maybe
find
this
a
is the
vertebral. Mm, yes.
maybe this is the case of skill.
Of what? Hello? 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 Doctor? Okay, candidate two, can you join us?
Hello, sir. I'm here.
Yes.
Hello.
Uh, gi- gi- Yeah, yes, doctor. Yes. Give me some differential diagnosis, please.
So this can be a case of sickle cell with avascular necrosis.
Okay, what else? But see here, are you يعني find or are we talking about H-shaped vertebrae? And the second point in sickle cell, do you think this is the texture, the acceptable texture for the whole?
No, sir. This can be, so
Okay,
can I
excellent.
see the sagittal Schwarman? It can be,
Okay, what happened here? What is the
there
name
are
of
multiple
this treatment?
end plate
Yes, excellent.
defects. Yeah, so
What
this can be
happened for
Schwarman's
the
disease.
individual? Okay, okay. If I will accept. Please, integrate um, the end plate abnormality and this one, the abnormality in both hip.
Yes.
What do you think about?
Uh,
See, I will show you.
Gotchers.
I
It
will.
can it be
Yes.
Gotchers disease?
Okay. Okay. What else? See, this is part of a skeletal survey. What happened here?
Mm.
What happened? See,
The
see
end of
here.
radius, the distal end of, um,
Excellent. There are some abnormality here in the
yes.
epiphysis of the red. So we have abnormality in this epiphysis, okay? And we
Yes.
have another abnormality in the spine.
Mm.
Hmm.
Multiple
So
epithelial dysplasia.
excellent. Again,
Multiple
what is
epithelial dysplasia.
excellent? Spondyloepiphyseal dysplasia. Why?
Dysplasia.
Yeah.
Spondyloepiphyseal.
Yeah, what happened? Thank you, doctor, so much. They are bilateral replacement of the hip. Okay. And this vertebrae is looks like there are some abnormality, irregularity, vibration.
Mm.
And then our candidate asked
Yes.
for lateral. Here,
Mm.
this is not normal at all end plates. All. Okay. All the
Oh,
end
yes,
plates
sir.
looks like Schwarman syndrome or abnormality. If I give this alone, okay, it is acceptable if your diagnosis is Schwarman syndrome. But in combination of other epiphyseal abnormalities, so the acceptable diagnosis here is spondyloepiphyseal dysplasia. Why?
Okay, sir.
Because there are bilateral hip abnormality. And here, look here, the radius. This is not normal. It looks like flat. Here, there are something, at least include within some few differential diagnoses. Sickle cell may be acceptable if you find another criteria of bone abnormality in sickle cell. What is the other criteria? What? Like other bone infarction. So the bone must be overall sclerosed. See here, the bone
Sclerosis.
other
Mm.
overall normal
No.
except the spine.
No.
And
Mm.
see here, my colleague, the spleen is normal.
Mm.
No any gallbladder stones, no H-shaped vertebrae. Okay. So it was a case of spondyloepiphyseal dysplasia. Thank you,
Okay,
doctor.
sir. Okay, sir.
Next candidate.
Sir, this is
Yes,
my
sir.
case. I'm second candidate. I
Okay,
was.
خلاص you participate because you participate. Thank you, doctor. Third candidate.
Yes, sir. I'm candidate three.
Okay,
Mhm.
doctor. This young age patient with no history. This patient with no history, even his age not mentioned here. We have a series of X-ray. Look here, here, here.
All right. So I'm presented with a scheduled survey of a child in an infant age group of a child. I don't know the exact age. However, I can see that there is um, rod seen in the bilateral femora, and the bone density is reduced, and there is bulbous expansion of the epiphysis I've noted in the distal femora, and in the chest, I can see that there is some deformity of the rib cage, and there is decreased bone density of the entire bones. Can I look
Yes,
at joints once again? Um, at the hand and the knee joint. Yes, in the hand, I can see that there is bulbous expansion of the distal radius, and also there is positive ulnar deviation, positive ulnar radiance. Ulna is more forward, and there is decreased bone density of all the carpal bones with loss of the joint space. There is also
yes,
loss of the joint space between carpal and metacarpal bones, and also between the metacarpal and proximal phalangeal bones. Keeping in view these findings, my differential diagnosis would be of juvenile idiopathic rheumatoid arthritis. Other differential could be
doctor,
of
1 second. 1 second. Do you think idiopathic rheumatoid arthritis,
yeah, bone
this
density would not favor. Yes, there is also bowing of the long bones and decrease in the bone density. These the changes could be due to any underlying pathology which is affecting the bone forming process. My differential could be of osteogenesis imperfecta because I can see the
excellent?
rods in the bilateral femora and also in the tibia with decreased bone density, and there is also some soft tissue swelling. This could be due to the this bowing, and it could be due to the fractures of multiple ages with some callus formations. Um, I like to know the any previous imaging if available for comparison, and otherwise
Thank you, doctor,
I'll
so
send you
much.
the reference,
Thank
and you
you so
can
much.
provide for the guide.
Okay, thank you. It was a case of osteogenesis imperfecta. Doctor, don't talk about juvenile rheumatoid arthritis in, see, the
Okay.
problem is generalized in all the bone. Second, the rheumatoid juvenile arthritis is almost monoarticular. Okay, this is a multiple deformity, gracile bone, fracture, deform, everything. So with reduced bone density. So either first possibility is osteogenesis imperfecta, less likely to be non-accidental and others. See,
Mm.
marked marked bone affection. Thank you, doctor, so much. Next it.
Thank you, Doctor.
Assalamualaikum, sir.
Salam. Doctor, this patient, 1 second. Okay. Male patient for checkup. No problem.
Okay, I am provided with a pediatric age group patient, frontal radiograph of lower abdomen and partially visualized bilateral femur and knee joints in a frog-like position. I can appreciate diffusely increased bone density of the lumbar vertebrae and bilateral femur and tibia as well. I can appreciate multiple calcific densities in the region of bilateral femoral epiphysis. There is a widening of pubic symphysis in the midline. The both femoral both proximal and distal long bones are short, and there is a slight widening of the metadiaphyseal ends as well. Proximal and distal metaphyses are flared. So the soft tissues appear normal. The evaluable sacrum appears normal. I
What about what
cannot.
about this and this?
So in the hands, on the lateral radiograph of the thoracic and lumbar spine, I can appreciate reduction in the height of the vertebral body as well as antero-inferior vertebral body beaking. The vertebral shape is deformed and there is shortening as well as deformity of the entire vertebral spine. So I would like to see the hand X-ray as well to further conclude my findings. So in the hands, I can appreciate the different epiphyses of the bones are punctated and having multiple ossific densities around it. So keeping in view all the findings, I'm thinking of a variety of the skeletal dysplasia that is having the name of dysplasia punctata, I guess, in which multiple epiphyses are punctate. Second possibility would be in this case case of mucopolysaccharidosis. However, I cannot appreciate any pointing of the metacarpals, and there is rhizo and mesomelic dwarfism as well.
Thank you, doctor, so
I would
much
like
again. Thank you. Thank you. You are very nice. Very your style of telling the details is very interesting. See, my colleagues,
thank you.
this is punctation of the epiphysis. See? And there are multiple platyspondylili. Flat, flat, all. Most of it are flat. Okay, my colleague. And also here, some punctation. So the diagnosis of chondrodysplasia punctata. Chondrodysplasia punctata. The most striking abnormality here, this, look here and look here. What happened? No epiphysis, but just dots of calcification. Okay, so this is a classic case. A classic case. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Thank you.
Assalamu alaikum, sir.
Ma'am.
So this is X-ray thoracolumbar spine of a skeletally mature patient. I can see multiple. There is reduced in the diameter. There is reduced in the height of vertebral body at multiple levels, and I can see on the lateral view. I can see anterior as well as inferior beaking of multiple vertebra. So the differentials include mucopolysaccharidosis. First differential will be mucopolysaccharidosis. So I would like to see other imaging or films if available. Okay, so this is X-ray of the arm and the forearm, where I can see that there is bowing of the distal tibia, distal radius, and there is broadening of the metaphysis as well. There is a negative ulnar variance, and I think this is a pseudo medium deformity.
So what's your final diagnosis?
So, sir, keeping in view the findings, my differential would include mucopolysaccharidosis.
Excellent.
I will advise for ultrasound abdomen as well as I will inform the finding to the
Thank you.
physician.
Thank you, doctor. I will tell you, my colleagues, something to pick up easily the mucopolysaccharidosis. What happened in mucopolysaccharidosis? The mucopolysaccharides deposit in the bones. So it restricts the growth of the bone. Look here. Look. Defective growth. So it is a process of defective growth. So you will find all the epiphyses are smaller, and the spine, see, have something very smaller. So it is central peak, central peak, central peak. Plus these deformities. Okay? Deformities everywhere. But a general word for mucopolysaccharidosis in bone, it restricts the growth because it is abnormal deposition of a material. So it occupying the blood vessels, by the way. Thank you so much. Mucopolysaccharidosis is a polysystemic disease affecting the brain. And yesterday, I show you one MRI brain of mucopolysaccharidosis. Next candidate.
Thank you, sir.
Welcome. Next. Hello. Next candidate. Any candidate? Hello?
I'm sir, and candidate number 8. Yes, sir.
No problem. Come, doctor. Come. Go
Okay.
on. This patient has bilateral hand pain.
Okay. Sir, I'm provided with sir, age of the patient. Can you tell me?
He is adult patient.
Okay, adult patient. Okay, sir, I'm provided with an AP hand of both hand. Sir, in this, I can appreciate that. So there's a mild raised density of the bones. Apart from this, I'm seeing that there is no joint abnormality. All joints are supposed to be fine. Joint species are preserved. I don't find any erosions. I also want to look for the radiocarpal joint. There is a small old fracture of the right process. Also,
What else? What else?
I don't
See,
find any
what about this
periapical
soft
region.
tissue? Doctor, what about this soft tissue? And
So
what about
there's a
the length of each phalanges and the cortex? Tell me.
Okay, sir. Sir, the soft tissue density appears to be raised and also some cortical thickening identified involving the metacarpals and which is obliterating or which is reducing the medullary cavity. It is predominantly involving the proximal phalanx of both hands as well as metacarpals. So cortical thickening is also there. But sir, there's no erosions seen in this.
What?
Sir, I want to ask about the history of the patient, about thyroid profile of the patient, as well as any previous X-rays. Sir,
What is your concern? What
sir,
is
I was
your
concerned
concern?
about thyroid ectopathology. I was suspecting. First, I was suspicious for raised bone marrow density.
See, but no periostitis. What
Yes,
else?
sir.
I will help you. This is
Sir,
the length of
then,
this phalanges
sir, was
is increased.
yes, sir.
What else? Hello?
Okay. Yes,
Hello?
yes, sir. There's so then yes, sir. Sir, osteopetrosis, I was first of thinking because of raised bone density, but if
No.
the length is increased, then I will think about Marfan syndrome and homocystinuria, in which there's a limb discrepancy. Hello, sir. Sir, I'm audible?
If
Hello?
I show you this, tell
Okay,
me,
sir. Okay, sir.
what's your
Okay, sir.
diagnosis?
Sir, then, yes, sir. Then, sir, acromegaly would be my diagnosis because the thickened calvarium and there is a raised, like, pituitary fossa appears to be raised. Also, sir, there's a hyperinflation of frontal as well as maxillary sinuses, and there's bone density the whole of calvarium appears to be thickened with frontal bossing.
What's your
And then,
diagnosis?
sir,
What's your
acromegaly.
diagnosis? Thank you,
Acromegaly.
doctor. Take care, my colleague. Some cases will show a subtle finding, like soft tissue thickening, like here the cortex it's little bit thickened, and there are widening of bases of the distal phalanges. See? See here? Wide,
Yes, yes.
wide. And
Spirit like.
there are, look here, some osteophytes.
Um,
Very, very subtle finding. Anyway, it was a case of acromegaly. At least the soft tissue here is increased. The lens, see, يعني, it looks like increased. The finger is not normal. This is, I know, this is not the classic ass of a spade sign.
yes.
Okay. So I bring this atypical case. Thank you, doctor, so much. It was a case of acromegaly. The skull is diagnostic. No need to talk about. All of you know the science, but take care from enlarged cell now. Thank you.
Thanks.
Next candidate.
Assalamu alaikum, sir.
Alaikum assalam.
So this is
See here. I'll describe.
yes, sir. So this is a frontal projection of both hands. And
Yes.
sir, can I please know the history? Sir, can you please tell the history?
No history, no history. This serial skeletal survey. You will tell us the
Okay.
history. Yeah, go.
Okay, so this is a skeletal survey, and these are X-ray hands frontal projection, and it is showing a diffuse increased bone density, and there are, sir, I can see some. There are hook-like osteophyte formation noted at the metacarpal heads bilaterally, and they're symmetrical. Other than that, I don't see any erosions or any mm, marginal erosions. I don't see any. Sir, so this could be a case of hemochromatosis. I'd like to see.
Here.
Uh,
What happened there? What happened?
okay, so this is X-ray lateral view of the foot, and it is showing reduced talocalcaneal joint space with the this looks like the talocalcaneal coalition with the C-shaped configuration, and it's a high arch.
Doctor, what is this?
Yeah. So
What
this
is
is
this?
calcaneum with inferior spur formation.
No.
Calcaneum.
What he measure here?
Oh, so the heel pad thickness is increased. It is
So, what
2.9.
are you saying about?
Okay,
What is your
so
concern?
the heel pad thickness is increased in cases like acromegaly. Um,
Look here. What is
okay.
your opinion?
Yeah, sir. So this is the frontal sinuses are enlarged in size and mandibular size increase. I'm looking
And
at the
the
picture. Yeah, the sella it is enlarged in size. So
see
this is
here,
the case.
I
Yeah.
used the arrow and I
Yeah,
indicate
yeah,
here.
sir. Yeah, I did not pick up your hint, but yeah, yes, sir. This is a case of acromegaly.
Okay, what is this? S of a spade sign.
Yeah,
See?
this is spade sign.
Okay?
Yeah, yes, sir.
Okay. Okay, thank you.
Thank you, sir.
My I just explained to you two different cases of acromegaly. The examiner will start from here, my colleague, from the periphery.
Mm.
Because if you didn't suspect in acromegaly, he will not give you this at all. This is in the last. He may start from here or here. And you should tell, doctor, there are increasing fat bed of the heel. Okay, thank you, my colleague.
Thank you, sir.
Next candidate. Next candidate. Any candidate?
Yes, sir. Assalamu alaikum.
Am I
Salam.
audible?
Yes,
I'm
yes.
candidate 10.
This patient has cough.
Okay.
Tell me your diagnosis. I will not give you other than this scout.
Okay,
Tell
so
me.
there is anterior bulbous enlargement of the anterior ribs, and so the vertebrae shows. I'm looking for the presence of any H vertebra, and there is no snow capping of the humeral head. The other possibilities,
Doctor, what happens
yeah,
generally for all bones?
there is decreased bone density with enlargement of the
Okay, what happened here? In the here.
Okay, so these
What is
are
this?
extramedullary hematopoiesis.
Okay. What is your concern or diagnosis?
Sickle cell disease or
No, 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 no.
thalassemia.
Hemolytic disease, you can, okay, tell like this, but
Yeah.
not sickle cell.
Okay.
Okay?
Yeah.
Look here. See?
Yeah.
See? This is the extramedullary hemopiosis. And what is this?
This is increased iron deposition within the liver, so increased density of the liver.
Okay?
And the
Hemochroma.
pancreas hemochromatosis. So I'm looking for the
Okay.
presence of any primary or secondary causes. So I cannot see spleen here.
Okay.
And
Thank you, doctor. Thank you so much. This is a case of a thalassemia or hemolytic anemia.
Okay.
What happened here, my colleagues? Expansion of all the bones, especially the anterior part of the ribs associated with osteopenia. If you look here, at least you can see paravertebral and here, soft tissue. So it is a hemolytic anemia. Why this is not a sickle cell? Sickle cell cause infarction. You should see here, H shape. H shape. Okay. Thank you, doctor. Next candidate.
Thank you.
Next candidate. Any candidate?
Sir, Assalamu alaikum. I'm candidate 12.
Okay. Now, tell me the finding.
Okay, so this is X-ray right hand frontal projection of a pediatric age group patient in which I can appreciate that there is diffuse sclerosis of all the bones without any predilection. It is diffusely involving all of the bones. There is also, I can appreciate that there is acrosteolysis of second and third and first terminal phalanges. The acrosteolysis pattern is more like central, and there is there is quite dense sclerosis with obliterating of cortex and medullary differentiation. I would like to give a skeletal survey for all of the other bones as well. Based on this hand X-ray alone, my imaging findings are suggestive. This is frontal and lateral views of the right leg showing tibia and fibula of the same patient, in which I can appreciate that there is a diffuse bony sclerosis of all the bones. Also, the mid shaft of the tibia is showing a inducency within its center, which is partially united with adjacent osseous deposits, giving the periosteal likely due to a callus formation due to some recent fracture. The fracture looks like incomplete, and looks like a type of insufficiency fracture or a loser zone. The bone's
What's your
density.
differential diagnosis?
My
What's
differential
your
diagnosis is that it can be pycnodysostoses or osteopetrosis.
excellent?
I have kept
Excellent.
pycnodysostoses on top because of the acroosteolysis, which is not a feature of osteopetrosis. Next, I would like to do a skeletal survey with the lateral view of the mandible to see angle of the mandible because it is quite diagnostic. This is the MRI brain spot image flare. This is
What
T2
is
weighted.
that? Okay. What is the name of this sign or this diagnosis? What is this?
Sir, there is frontal pointed
Okay.
pointed calvarium in the frontal
Okay,
region.
What is the name of this deformity?
Lemon skull?
No.
No,
Okay.
it's not lemon. Sir, there's cranial. I will look for craniosynostosis. There is frontal.
Okay. This
Is it
yes.
boat shaped? Boat shaped skull. Craniosynostosis. What I'm concerned for. That
Okay, this
it
is
might be.
synostosis. What is the name of deformity?
Sir, it is. Sir, I don't know. It is due to coronal suture fusion.
Mhm.
I forgot the name. Boat shape maybe, or I forgot the name.
Not both shape. See, there are, if I show you, I will show you the 3D. There are fusion of this suture. This one.
Metopic.
So, metopic, excellent. So, this is a trigonocephaly. And this is another criteria of the pycnodysostoses. Okay. Thank you, doctor. You are amazing. Your style really is very brilliant. Thank you.
Thank you, sir. Thank you.
See my colleagues here, there are acroosteolysis associated with marked cortical thinning and narrowing of the bone marrow. This is a classic pycnodysostoses. Doctor, your style and differential is really, really more than amazing. Thank you so much. Next, edit. Any candidate?
Hello. I'm candidate 30.
Okay.
Hello.
Okay. Go on.
So this is
This patient has
chest radiograph.
cuff.
Okay, this is a chest radiograph frontal projection of I couldn't make the probably pediatric age group. Yeah, I can appreciate that there is
Sure, doctor. Are you sure this is a pediatric age group?
no, I think this is adult because I couldn't as the long bones are not okay.
Okay.
So I can appreciate that there is flowing, there is increased density of the ribs along left lateral chest wall.
Yes.
In the mid lower zone, and I think it is in the form of flowing candle wax appearance. In the form of candle wax appearance, so it could be due to maloriostosis. In the rest of the lung fields are clear. There is no evidence of pneumothorax. Both costophrenic angles are clear. Cardiomediastinum is unremarkable. The other, so in summary, in this patient.
What is melorodystosis? What is the name of this sign?
The flowing candle wax appearance.
Excellent. What is melorodystosis?
There is flowing increased density with the flowing ossification along the margins of the bone, giving the appearance of candle wax appearance.
Okay, it is candle wax appearance, but what is the underlying pathology?
Sorry, I have no exact idea. I think there is metaplasia bone. I'm not sure.
Osteitis, at least osteitis. Okay.
Okay.
Osteitis. What happened here? Periosteal reaction and the cortical thickening. This is a type of osteitis. Thank you, doctor, so much. This sign is a dropping candle wax appearance. Okay, thank you so much. Other differential diagnosis, especially if this patient is adult, you can talk about sclerotic metastasis, but sclerotic metastasis will not be along the axis like this. It will almost cause some distraction, and it tended to be focal. Okay, my colleague. Thank you so much. Next candidate.
Yes, sir.
Any
I'm
candidate?
13. I'm 14. Yes.
No problem.
Any history, please?
10-year-old female patient presented with recent cuff and
Okay.
left side chest pain.
Okay, so I'm presented with the frontal radiograph of a 20-year-old female presenting with a cough and left-sided chest pain. I would like to have a systemic review. Okay, so the lungs are clear, no pleural effusion or pneumothorax. The heart size is normal. Regarding the thoracic cage, the ribs appear normal on both sides.
Okay.
I'm not happy
Okay.
about the left scapula. It shows an area of lucency irregularity with mottled calcification associated with soft tissue thickening on the left side of the lower neck and the upper anterior chest wall or the posterior chest wall. I would like to correlate with cross-section imaging, CT scan with IV contrast, or MRI for the soft tissues. My differentials would be bone tumors or, okay. So this is the MRI, axial. So there is a large soft tissue mass at the region of the subscapularis muscle.
You didn't tell me the name of the sequence.
Okay, so it is fat suppressed.
Excellent.
Okay, the CSF is high, so this is C2, fat suppressed. Okay.
This is clear, no problem. What happened here?
Large soft tissue mass at the subscapularis region involving the muscle and causing bone destruction, infiltrating the adjacent soft tissues. So this is
Affecting which area? Supra, scapular, muscle or region? See? Completely suprascapular. So what's your differential diagnosis or the diagnosis?
Okay, the patient is 20 years of age. The first, the top differential for any bone lesion is metastasis. It is very big.
10 years.
Again, primary.
No. She is 10 years.
10 years. Okay, fine. So 10 years with a bone mass in a flat bone, my top differential would be Ewing sarcoma.
Excellent. What is the first line of treatment of Ewing sarcoma?
Chemotherapy, I guess.
Excellent.
Or debulking followed by therapy. Yes.
Do you know the curative percent? How many patients respond?
I'm not sure, honestly.
More than 50%, because this question I ask in every session, MSK session. Why? Because I have been asked in the Wi-Fi. My Wi-Fi.
50%? Okay, that's a good ratio. Thank you.
I think more than 50%. Anyway, thank you very much, Dr. Naam. Really, yeah, you pick up a very difficult case. By the way, my colleague, it was a case of today. Why? First, we are in MSK session. So this is the first of all. Second, it is very subtle here, really not well visualized. So this is the normal scenario of Viva. You don't know which system the examiner will give, which disease, which site. Okay. So see here, there are distraction here at least, and look here at the soft tissue. At least you must tell the examiner about the discrepancy of here and here, and ask him to zoom. My colleagues, the examiner are become very happy when you ask to zoom or when you to zoom, but don't ask at all to window. Most of them are not welcoming when doing the photos. This is my experience. However, يعني ask. So this is the key, and then MRI, it was very clear, and Ewing sarcoma. Next candidate, we have candidate 15 or not? Dr. Nagam,
Yes, we have.
where?
Please join.
We lost the
And
candidate 15.
we skipped candidate 4 to 8. Candidate 4 to
Where,
7. If any is
where is
around, join.
anyone here online? Any candidate? Okay, that is enough.
Sir, I can.
Okay, last one. Doctor, this is neonate. Neonate, and just he has been some circumscribed 20. He has circumcision, sorry. He has circumcision 25 days ago. Suppose he is 1 or 2 months neonate. Yeah, go on. Hello?
With yes, sir, can you hear me?
Yes, go
Hello?
on. Yes, yes.
I'm presented with a frontal radiograph of bilateral limbs, lower limbs of a neonate, 2-month-old. I can
Yes,
see
yes.
that there is lucency in the metaphyseal region of right tibia.
Okay.
I cannot see the similar lesion in the left side.
Okay.
The left,
Do you,
the right.
doctor, 1 second. Do you think this is just lucency?
There is irregularity and
And
lucency in
something more dangerous.
Yes.
Anyway,
along
continue.
along with
Continue.
periosteal thickening.
Excellent.
So my diagnosis would be osteomyelitis, acute osteomyelitis of.
Excellent. But this is erosion. See, this is not just irregularity, just lucency. Here, there are compare. This is a metaphysis and يعني proximal part of meta diaphysis junction. Compare here, my doctor. Second, see this one, sclerosis and periosteal action. Thank you, doctor, so much. It was a case of osteomyelitis in neonate. See, very atypical case. And this is a typical scenario of Viva exam. Thank you for all of you, my colleagues. Next week, I will
Thank you
tell
so much,
Dr.
sir. Thank you so much.
Welcome to do another 6 day for all of you. Thank you. Special thank you from all of our hearts to our coordinator, Dr. Nagam. Really, you are doing a great job. Without Dr. Nagam, I think I can't conduct this week because really, she helped us too much. I didn't ask her any question. Every day she gives us the list, despite the big dilemma. Thank you, Dr. Nagam, for your great effort. Thank you for all
All
of
of
you,
you
my
are the
colleagues.
most welcome. Thank you.
Thank you. Goodbye.
Bye.